All right, today we are diving into one of the most powerful processes in all of nature, childbirth. It's something we often see in a very idealized light. But what's the full story? We're going to break it all down, the incredible mechanics, the step-by-step journey, and the serious risks to get the complete picture. So let's jump right in.
So you hear about the beauty of natural birth all the time, right? And it really is an incredible thing. But is that the whole story? To really get it, we've got to look at both sides of the coin, the amazing journey itself, and the very real challenges and risks that can come with it.
Okay, so first things first, let's trace the journey of a natural birth. We're going to follow it from the very beginning to see how the body prepares for this massive event.
So, how does it all start? Well, the first signs can actually be kind of subtle, but they definitely build. Usually it kicks off with this nagging back pain, and then you start feeling those uterine contractions getting stronger and more regular. It's like the body's firing up its engines.
But the real, unmistakable signs that it's go time are two things. First, the mucus plug, which has been sealing the cervix this whole time, is released. And then, the waters break. When that happens, it's a crystal clear signal from the body, this baby is on its way.
And once those signals hit, labor really gets going. The whole thing unfolds in these very distinct, very powerful stages. So let's break down what actually happens next.
You can really think of the delivery in four main steps. First up, you've got cervical dilation, basically creating the exit. Then comes the heavy lifting, the uterine contractions and pushing. The third step, of course, is the one everyone's waiting for, the baby's actual delivery. And then there's a final super important step, delivering the placenta. Let's dig into each of these a bit more.
Okay, for this first step, there's one magic number you need to know. 10 centimeters. That's the goal. The cervix has to open up to that exact width so the baby's head can pass through. And believe it or not, once active labor is really in full swing, getting to that 10-centimeter mark can take just about 20 minutes. This next part is it's a brilliant piece of biological engineering. The uterus does this amazing two-part job. So the top part contracts with incredible force, pushing the baby down, but at the exact same time, the bottom part down by the cervix does the complete opposite. It relaxes. It's this perfectly coordinated push and relax system. All right, so during those final pushes, the baby's head makes its appearance. Then there's this really key move where the baby's body actually rotates. This is so the shoulders can come out one at a time. It's a tight squeeze. After the shoulders are free, the rest of the body just slides out pretty easily. The cord gets clamped and cut, and there you have it, a brand new baby in the world.
And wow, what a moment, right? A new life is here. But, and this is a big but, this process, as natural as it is, can take a serious physical toll on the mother. And to really understand the complete picture, we have to talk about that.
So that brings us to the flip side of the coin. To get the honest, full picture, we have to look at the real challenges and potential downsides of a natural delivery.
And look, the list of potential issues it's pretty sobering. We're talking about things that can be long-term, like incontinence, or a loss of sensation, and even the risk of severe tearing. And something else the source highlights is that labor can be super unpredictable. Plus, and this might surprise you, statistically, natural births actually have a higher mortality risk for both mom and baby when you compare them to planned C-sections.
But out of all these challenges, the source really zeroes in on one as the single biggest drawback. And you can see it in this quote right here. It's the pain. The reality is the mother feels every single contraction. And this isn't a quick thing. It can go on for hours and hours.
Okay, so we've talked about drawbacks. Now let's talk about situations where a natural birth isn't just difficult, it's downright dangerous or even impossible from a medical standpoint. These are what doctors call contraindications.
And the source material lays out at least 10 major medical reasons that would prevent a safe natural delivery. In these scenarios, a C-section isn't just another option on the table, it's absolutely necessary to keep both mother and baby safe.
The first group of problems has to do with the baby itself, its size and its position. Sometimes it's just a matter of physics. The baby's head is simply too big to fit through the cervix. Or the baby might be in a breech position, that's feet first, which makes delivery incredibly risky. And then there's the absolute nightmare scenario where the umbilical cord is wrapped around the baby's neck.
Next up are issues with the mother's body, specifically the placenta and uterus. For instance, the cervix might just not dilate. It stays shut, creating a total roadblock. Or the placenta, the baby's lifeline, can cause huge problems. With placenta previa, it actually moves down and blocks the exit, trapping the baby. And even scarier is placental abruption. That's when it detaches way too early, causing massive, life-threatening bleeding.
And finally, the mother's general health is a huge factor. Carrying twins or triplets, for example, puts an enormous strain on the body. Conditions like preeclampsia with its super high blood pressure make labor incredibly dangerous. If the mother is of an advanced age, her uterine muscles might not have the strength needed for pushing. And this is a big one. If she's had a C-section before, there's a risk the uterus could actually rupture from the force of the contractions.
So, after going through all of this, the amazing process and the very serious risks, what's the bottom line? Well, it really all boils down to one simple idea. Here's the most important takeaway. The goal isn't to have a specific kind of birth. This isn't some competition between natural and C-section. The only thing that truly matters is that both the mom and the baby come out of it safe and healthy, period. And understanding all these realities is what allows for the best possible decision to be made.
So I'll leave you with this question to think about. Knowing the whole story now, from the incredible biological design to the very real, very serious risks, how does that change the way you think about childbirth? Thanks for digging into this with me.
A normal birth is spontaneous in onset, with no complications throughout labor and birth. It's a birth of a single infant in vertex position between 37 and 42 weeks of gestation. Normal labor starts with either regular contractions that affect the cervix or with rupture of membranes followed by a spontaneous onset of contractions. Respectful care. Giving birth can be a vulnerable and painful experience, and every woman and her companion deserve and have the right to be treated with kindness, dignity, and respect. Fear of being mistreated might cause the woman not to seek the skilled care that she needs. Fear can stop contractions, complicate the labor, and will give the laboring woman a bad birth experience. As a health professional, it's your duty to make the laboring woman feel in safe hands at all times. Remember to communicate with respect and listen to questions and preferences and explain medical procedures and what to expect in a simple and clear language. Ask for permission before you do anything and respect her privacy. Always allow the woman to have a companion of her choice during labor and as long as she is at the facility. Do not leave a laboring woman alone. If you must leave, make sure that someone else can stay with her. Initial assessment. When a laboring woman comes for care at your health facility, you should perform a quick and initial assessment of the woman and the fetus, determine the stage of labor, take history, and act accordingly. See practical procedure for further instructions. Calculate her due date and gestational age. Proceed with an abdominal examination. Feel for contractions and note down frequency, duration, and intensity, as well as how the woman is coping. Measure fundal height and look for cesarean scars. Assess her abdomen for the fetal presentation, descent, and number of fetuses. Listen to the fetal heart for 1 minute right after a contraction. If the fetal heart rate is between 110 and 160, the baby is tolerating the labor well. If there are contractions, perform vaginal examination to determine the stage of labor, fetal presentation, position, and membrane status. First stage, latent phase. The latent first stage is characterized by painful contractions and changes to the cervix of the uterus with dilatation up to 5 centimeters. Progression might be slow and can even take days. Listen to the fetal heart rate intermittently and perform vaginal examination at intervals of 4 hours. Frequent vaginal examinations increase the risk of infection. The woman can usually be sent home if she's in the early latent phase, her membranes are intact, everything is normal, she lives with easy access to the facility, and the woman consents. Inform the woman and her companion of the signs of active labor and danger signs and welcome them back at any time. Some women need admission, care, and support in the latent phase. Recognize the woman's experience and feelings. First stage, active phase. The woman is in active labor when she has contractions that are regular with increasing intensity and the cervix is dilated at least 5 centimeters. If she does not meet these two criteria, she is not in active labor. The first stage, active phase, usually does not last more than 12 hours if the woman gives birth for the first time, or more than 10 hours in subsequent labors. If you diagnose active labor too early, you will increase the risk of unnecessary and potentially harmful interventions. Never try to shorten labor with oxytocin or rupturing membranes if the woman and fetus are doing well, the cervix continues dilating, and labor is within normal limits. When the woman is in active labor, begin labor care. Explain what to expect and inform her continuously and respectfully. Start the labor care guide, document findings, and note the time. Good documentation helps decision-making and improves clinical outcomes. What is not written in the record is legally considered to not have been done. Every 30 minutes during the first stage, active phase, you must listen to the fetal heart rate immediately after a contraction, monitor the contractions, count the woman's pulse, assess the woman's mood and behavior. For further details and normal ranges, see practical procedures. Document your findings and provide care accordingly. Support. Giving birth can be a long, painful, and exhausting experience. The body's oxytocin works better if the woman feels safe. If the woman is scared, stressed, or does not feel respected, this can interfere with the normal birth process. Make sure that the environment around the woman is clean and private. Help her to the toilet throughout the labor period. It's important that the woman get something to drink and eat during labor. Make sure she gets something light to eat and offer her at least 1 cup of water, tea, or juices to drink per hour. The pain often increases throughout labor until the cervix is fully dilated. Use your experience and knowledge to support and encourage the woman and talk her through the contractions. Give comfort along with her companion by offering massage, help her to shower, help with breathing techniques, help her find comfortable laboring positions. The ligaments in the pelvis get more flexible during pregnancy to support descent of the fetus, and in order to benefit fully from this, it's important that the woman is in motion and changes positions throughout labor. To support descent of the fetus, it can be very beneficial to utilize gravity by adopting an upright position during labor and birth. Second stage, cervix fully dilated. The second stage of labor is the period of time between full cervical dilatation and birth of the baby, during which the woman has an involuntary urge to push as a result of expulsive contractions and descent of the presenting part of the fetus. The duration of the second stage of labor varies. For a woman giving birth for the first time, second stage is usually completed within 3 hours. In subsequent labors, second stage is usually completed within 2 hours. You should always prepare for birth when a woman enters the second stage of labor, or even earlier if she has given birth before. Prepare 10 international units of oxytocin or 400 to 600 micrograms of misoprostol if oxytocin is not available. Have the delivery tray ready and check items for newborn resuscitation, including bag and mask. Prepare a clean and dry surface under the woman and have warm towels or cloths ready for the baby. During the second stage of labor, you should monitor the fetal heart rate, contractions, and visually check for descent of the fetus every 5 minutes. The woman should be encouraged to empty her bladder every 2 hours. You should only catheterize the woman if the bladder is full and she is unable to empty it on her own. A full bladder can cause prolonged second stage of labor and interfere with uterine contractions during the third stage of labor. If second stage is still within normal limits and the fetus is still at the pelvic midpoint, it is not yet time to give birth. Encourage the woman to change position and to breathe through contractions. If second stage has bypassed normal limits, see prolonged labor. If the fetus has reached the pelvic floor, it is now time for the woman to push. Second stage, delivering the baby. Let your assistant know that birth is imminent. Support the woman to give birth in the position she chooses, preferably as upright as possible to facilitate physiologic birth. Encourage and support the woman to push according to her own urge, with legs relaxed and open to allow slow and progressive stretching of the perineum. Following are recommended birth positions: on hands and knees, half sitting, lying on her side, standing. If progress is slow due to insufficient contractions, encourage the woman to stand up or half sit. If there is no progress after 1 hour of pushing with strong contractions, the woman and fetus are at risk and may need advanced care. See prolonged labor. If labor and descent are progressing normally, perform hand hygiene and put on double gloves. Support the perineum with your hands and keep the baby's head flexed towards the woman's back. When delivering the head, instruct the woman not to push during contractions to reduce the risk of trauma to the perineum and allow the head to deliver gradually. Support the perineum until the posterior shoulder is delivered, as it can also cause damage to the perineum. Avoid the following harmful practices: fundal pressure, routine episiotomies, manipulate and stretch the perineum, manipulate the baby's head, reach in to deliver arms after the shoulder is born. This should only be performed in shoulder dystocia. Continue to gently support the birth of the head by placing one hand against the baby's head. When the head is born, allow it to rotate naturally. Do not suction routinely, even if there's meconium in the amniotic fluid. Only wipe the baby's face with a clean cloth. Check for the umbilical cord around the neck. If it's loose, slip it over the baby's head or deliver the baby through the cord. Gently pull the head downwards to deliver the anterior shoulder and then lift upwards to deliver the posterior shoulder. Immediately place the baby on the mother's abdomen and note time of birth. Congratulate the mother and her companion.